Good evening and welcome to Stop Being Degenerative, How to Protect Dental Crowns from Microleakage and Secondary Decay. I'm your host, John Camisi, speaking to you from beautiful Mount Pleasant, South Carolina this evening. The weather here is gorgeous. I hope it's good by wherever you happen to be. Today, we're going to talk about a subject that may not seem that important, but actually it can contribute to the success or the failure of your final restorative process, especially when you're working with indirect material cementation. And direct bonding and indirect bonding of our restorative materials are actually, in my opinion, more closely linked than many of us might actually think about it. So we're going to go through some of the science and some of my thought process, and let's see what we can come up with. And we'll have some time and after the presentation is done for question and answer. So please have them ready for me. All right, let's go on. Fundamentals. We're just going to discuss the fundamentals here. That basically dental decay and dental caries is an incredibly complicated disease and actually the most prevalent disease on the planet. You wouldn't think of that, but it's so very prevalent and so many people have it that we really need to look at this in a wider scale than I think we may have been doing for so long. And we also have to get into the idea that the teeth, of course, are alive and are living in a biologic soup that is constantly responding to the stimulus, the environment in which the teeth live in, which, of course, is the mouth, surrounded by the saliva, and, of course, the various acids and carbohydrates that we take in every day as part of our normal nutritional cycle. Also, as this paper from 2001 by Cho and Vogel discussed, that enamel is a semi-permeable membrane with a constant flow of fluids outward from the pulp. And the reason for that is that it's the tooth is trying to constantly counteract the acidic effect of decay that's occurring. So the dentinal tubules are actually conduits to provide the calcium and the phosphates necessary to try to neutralize the acid attack. And as long as the balance is such a way that the acid can be controlled, the problem is maintained and managed. So many studies have indicated and talked about this demineralization, remineralization process, which coexists during the entire life cycle of an individual's dental health or lack thereof. Caries is a dynamic disease process caused when there is an imbalance between the remin and the demin systems that are going on. And the pathological condition is occurs when the demineralization overwhelms the remineralization process. So as we showed in the previous slide, if the acid from the external aspect overwhelms the natural protective mechanism of the tooth to protect it with the calcium and the phosphates, then dental decay occurs. And interestingly enough, when the decay passes in through the enamel and breaks through to the dentinal tubules, those tubules where the calcium and phosphates have been coming up to try to protect the tooth can actually become a superhighway for the dental bacteria, decay bacteria, to actually progress faster and more deeply into the tooth than it would have otherwise. So its protective mechanism is actually sometimes detrimental when it becomes overwhelmed. And of course, the caries process occurs when the demineralization of the natural appetite by the acids are prolonged or produced by the bacteria and followed by the continued degradation of the organic matrix of the intracellular matrix starts to break down. And as the caries progresses, the degradation of the collagen fibrils occurs, leading to decreased mechanical properties of the dentin. And then you have cavitation and the overall collapsing in of the fragile enamel that is surrounding this dentin that is no longer supportive. And the caries process is initially reversible, as we talked about just a few moments ago, but this chronic ingression of the bacteria and the acids slowly destroy it. And it's arrested by the only way to stop the entire progression is to try to disturb the plaque in the biofilm, which is why the typical oral hygiene mechanism of brushing and cleaning interdentally with either floss or interdental brushes or water jet devices becomes so crucial in trying to manage things. Now, I know that in other parts of the world, this is not that easy to do, but there are mechanisms that we can employ. We do have interdental stimulators. We do have brushes of various types. The key here is to try to disrupt the biofilm before it enables the carious process to occur, because it's a battle that's going on in the mouth, as I like to show. This is one of my favorite slides to look at. There's a battlefield between the good and the bad, the protective agents and the destructive agents that are constantly there. And hopefully the protective agents are going to prevail, but that's not always what you and I see in our clinical practices. So we have a battle of the bond, in my opinion. Bonding, I've talked about this all the time. It's our friend and it's our enemy all at the same time. The reason is that we're trying to create this mechanism of infiltrating this plastic resin into an organic substance, the dentin. And we believe, as is illustrated here by an SEM by my good friend Umar Daoud, showing this beautiful hybrid creation with the dentinal tubules being penetrated by the resin tags. And again, this is lovely in the laboratory. This is what it looks like in the laboratory. This is not what's typically created when we attempt to create a hybrid layer in the tooth, because we have so many different factors that are constantly attacking while we work. Matrix metalloproteinases are some of the proteolytic enzymes which are always trying to degrade what we create. And this article by Leotarden and the group talks about this era of dentin degradomics going on, which is really a very, very appropriate terminology, which is why I talk about this being, we have to stop being degradative to the whole thing. Caries process involving the hybrid layer creation, trying to infiltrate this demineralized dentin is actually a process which may not really work as well as we think it does, even though there's so much in the literature showing up till now that it does do something. But the biggest problem is that the BIS-GMAs that we use and the bonding materials are all derived from a methacrylic acid. And basically, we're putting an acid into a tooth structure to try to restore it back to health. But isn't that a problem? Because we've just been talking about the acid attack that the tooth is trying to prevent from occurring in the carious process. And this wonderful article from several years ago, Amazing Odontoblast Activity, Autophagy, and Aging, talks about how the defensive mechanism of the odontoblast and the tooth, which we've described just a little bit ago, going on. But the biggest question that I always have is, how does the tooth differentiate between the acids of the bacteria and the acids that we're employing to restore the tooth? There isn't a way for the tooth to differentiate. It's going to have a response. It's going to not be happy with the acidic exposure that it's having. So again, there's something in what we've been doing that really sometimes confounds me. And it makes me wonder, how is this really working? And I know a lot of you out there have been doing this at least as long as I have. And of course, you're all fantastic and you are able to have restorations work for years and years and years without a problem. But I don't know. I saw a great deal in my private practice, and I see in our dental clinics and in our faculty practices, failures occurring by people and mechanisms that still are confounding in how it's working or not working. And again, JDR talked about this in this article several years ago, and it talks about the hybrid layer degradation occurs because of the acidic properties of all of the currently used adhesive systems. So again, there's an intrinsic flaw in, at least in my thinking. And again, I may be the only one in the world that thinks this way, but it's starting to make a little bit more sense to me as time is going by, that something that we're doing, if we're not replacing some of the important ions in the overall structure that we're trying to restore, we may be having more of a problem than we think about it. This wonderful article talks about composite failure with a life expectancy, of course, as I've talked about countless times, of being 5 to 7 years, considerably less than amalgam restorations, which seem to last forever. You know, I know there's a conversation out there about amalgam splitting teeth, et cetera, and so forth. And again, I don't know if that's accurate. Is it the amalgam that's splitting the tooth, or is it the occlusal forces that are generated because of other factors that are breaking the teeth? But again, we like to blame things that we don't have any control over, or we just don't like. The primary cause of failure, of course, according to this paper by Spencer, is that it's the degradation of the adhesive layer, resulting in marginal breakdown, round lines, secondary caries, etc. And especially if you're using a self-etching material and you are expecting your self-etchants to prevent and be able to penetrate into your enamel in the same way that if you would with total etching, well, I'm afraid that's not going to happen, because your self-etchant bonding agents are not acidic enough to basically etch the enamel effectively to prevent it from breaking down. So there's two things, you know, I teach my students this all the time, is that if you are going to use a self-adhesive, self-etching material, to do two things. Number one, bevel the enamel to remove, expose the underlying enamel, which will be more easy to penetrate into, and selectively etch, and then wash that off and place your bonding agent on the dentin if that's what you want to do. But if you don't selectively etch your enamel, you're going to be having some brown line problems going on. So the problem, as I see it, is that restorations may only last a few years due to the bacterial accumulating beneath the restoration, resulting in additional decay. And that's another issue that goes on. The bacteria that penetrates into the dental tubules really invades pretty deeply. And someone told me the other day, well, of course, our etchants are going to kill that. That's not necessarily true. And there are many studies that show that the etchant cannot penetrate into the dental tubule that much, especially for the short amount of time that we're using it. And perhaps an antimicrobial of some type might be the better thing, but that's another lecture altogether. And because it's left behind, it can continue to penetrate, especially when the bond breaks down. So we have to look at that. Wonderful paper by Annalisa Mazzoni, Tape, Ashley, and Bresci several years ago talks about how the matrix metalloproteinases in caries progression and creating a bond instability going on. And as underlined, it talks about the endogenous enzymes remain entrapped within the hybrid layer during the resin infiltration process. And the acidic bonding agents themselves, irrespective if it's total etch or self-etch, activate the endogenous proteinase proforms. Why? Because of moisture, because the dentin is always moist. We think that we're eliminating the water when we're creating the bonding, but unfortunately, that's not really happening. There's always going to be moisture coming up from the dental tubules, as we talked about earlier. It's the purpose of the odontoblasts to secrete these protective agents, and moisture and fluid from the pulp and from coming up from the odontoblasts is always going to be there. And again, that's one of the things. So both total etch and self etch still creating the problem and still activating the endogenous degradative processes that are going to occur over time. And again, same thing with this seismographic image that you see here. At the top, you see where there's the R in the upper aspect of the image. That's the resin. The HL is the hybrid layer, and the D is the dentin. And the green aspects are the proteolytic enzymes that are activated because of the bonding process. So that's what we're dealing with. And again, this may last 5 years, and then it'll fail. It may last 7 years, and then it'll fail. Ultimately, it is going to slowly corrupt the restoration that we're placing, direct or indirect. So there's a nice blow up of it. And again, this is from Franklin Tay, a lecture that he gave a while back, talking about the various types of matrix metalloproteinases that are present. MMP2, 8, and 9 are always in the collagen fibrils. They will actually use the collagen fibrils and destroy them when they get activated. So that's why when you go into a failing composite and you're drilling it out and it goes flying across the room, that's because it's been degraded by the MMPs. And why sometimes amalgam, it takes dynamite in order to try to get that last little bit off of the pulpal floor, because there is no enzymatic breakdown. And that's always been something that I clinically saw, and maybe you have as well. So water is needed for this proteolytic activation to occur. And again, as I've been saying, there's always going to be moisture present. And Tay and Pashley many years ago told us the way to increase the durability of resin bonds is to cover and get all of the collagen fibrils completely enveloped within the resin. And that would prevent it from having access to the water that is necessary for the enzyme activity to occur. But again, there's always going to be that section that for whatever reason, the bonding agent did not penetrate. And that's going to create the leakage, which is going to cause the biggest challenges to occur. And again, going back to Umar Daoud, he talks about the permeability and the intrinsic wetness, depending on the size and the patency of the dentinal tubules. Dentinal structure and permeability directly affect bonding. More increased moisture in the deep dentinal results in an inferior bond strength compared to the superficial dentin. In general, as he has found, the immediate bond strengths in deep dentin is about 30 to 50% lower than that at the superficial layer. And unfortunately, most of us are doing that. Even when we're creating crowns, depending on the structural integrity of what you're prepping, you're going to have this kind of limitation, which is why I lump both indirect and direct restoration bonding together into one group, which not everybody does, but there you go. And again, we have a lack of buffering capability by all of our resin products out there. And it enables a more opportunistic aspect for our bacteria with a karyogenetic penchant to become more viable and virulent over the course of time, because these restorations have a higher susceptibility to secondary caries, as we have seen constantly, and the literature continues to show us. Which leads me to one of my favorite arenas, as many of you know, is bioactivity and biomineralization. But the problem with bioactivity has become so commercialized in some people's minds that I'm liking to call it biointeractivity rather than bioactivity. It can mean the same thing, but I think there's an important differential here, as we'll discuss in a couple of minutes. Bioactive applications, biointeractive applications can be preventive, such as our sealants and our varnishes, can be restorative, can be involved with our pulp and root canal treatments, Definitely orthodontics, because bends and brackets have a high propensity of accumulating plaque because of patients' inability to really clean well. And if you don't have something to protect those areas, you're going to have some issues. And of course, the crown and bridge cements, which is a main focus of what we're going to be discussing during this time period that we're together. But it's all going to get there. Constant literature has begun to show us that these bioactive, these biointeractive glass fillers are able to produce a better protection against the marginal gaps of composites. And again, this article, which is with the Ferricane group right here, talks about bioactive glass containing composites having the potential to slow the development and propagation of secondary tooth decay at the restoration margins. So this is very important, and it applies to all of our restorative processes, in my opinion. And again, we did a study several years ago at MUSC with some of my pre-doctoral students, and we decided that we were going to try to see what would happen if we were to use a regular composite and some of these composite materials that have ionic glasses in them and activities, and what would happen. And we found that we really got some beautiful marginal integration with these materials. It showed us that we were able to stop the degradation. The very top figure one shows the actual breakdown of the composite tooth interface there, and all the others show some type of ability to create a mineralized interface here. And this is the SEMs that we created after putting these into an artificial saliva for 30 days, and it did show the improvement and the creation of various mineralization processes in there. So we had some really nice results with these products in this study. More clinical studies, 46-month report talking about the Activa bioactive materials. 4 years at this point in time. This was back in 2018 that Dr. Kroll did with Nate Larson, showing that it's durable, has many applications from primary teeth through permanent anterior and posterior teeth, and confirm the results. And they're able to resist fracture very, very well. So this is some of the materials that we have seen and worked with. And the same thing here in this paper talks about the postoperative sensitivity using bulk filled restoratives. And in this study, the conclusion said that the Activa bioactive restorative materials compared to Equia and to Sentient N, their post-op sensitivity was non-existent in the Activa materials versus the intervals at 1 and 2 months, and still present in patients treated with the Equia Forte and the Sentient N products there. More papers from University of Tennessee showing that the Activa products were able to create the resin tags as illustrated in the right-hand micrograph that you see there. So this is something that's continually being shown over and over again. And my good friend Salvatore Saro also showed that the material had no bond degradation when it was used with a bonding agent as compared to a traditional composite and bonding agent. So there's something about the utilization of materials that have an ion releasing capability that seems to be very, very positive when we're doing our restorative processes. And a lot of people say, but if you're putting a bonding agent down, doesn't that prevent the ions from penetrating into the thing? Well, we have to look back at this, is that after about 30 days, the immediate bond strength of our bonding agents starts to fail because of the water permeability situation. So as the moisture and the semi-permeability of these bonding agents, which originally were non-permeable, occurs, as we've seen in many studies, the ions that are present can then penetrate and help to form crystals, which on the superficial aspect can be extremely beneficial in trying to curtail and stop any kind of breakdown that's occurring. Another article, again, focusing in on the Activa materials, showing that compared to an Omacir and a conventional GIC restorative material, that there was the lowest microleakage seen in the biointeractive material that was being used at that point in time. And then a poster several years ago that was featured by one of Jack Farrakhan's students talking about the strep mutans biofilm and the ability of the Activa and the bioglasses to basically help to reduce the biofilm in the area and reduce the growth of bacteria. So when we're using these interactive materials, these ion providing materials, we're going to be able to really significantly hinder some of the breakdown that we're commonly seeing around things. And a paper by my PhD student, Ahmed, just a year or two ago, worked out this in vitro elemental and micromorphological analysis of the resin dentin interface. So we wanted to compare, again, what a traditional composite, a traditional bulk fill, how it would respond versus the bioactive materials as we went to them. So as this SEM shows, the gap between the restorative material and the dentin, there is no activity. It's essentially very low in any type of mineralization. So that gap is where your initial breakdown can occur. And when we use it with the bioactive material, we can see in the purple line, especially on the left, and above the purple lines on the right-hand side, the mineralization that is occurring. And this has been constantly seen in every other paper that I have read into this arena here, which brings us again to the cementing process. And again, I've been using the Activa products in my own personal practice, and we've also been using it at the college for quite a while now. And we're looking at incorporating this into the college as one of our resin luting agents. And again, in any type of thing, there's a process that's followed. We took a process when we originally brought in the Activa materials several years ago. Our students love them. They work out really well, very easy to work with. And the cement is the same basic principle and the same basic formulation as the others. The nice part about it is that, again, they're looking at this polymer matrix, which has this bioactive capability that is clinically been proven to minimize the risk of any kind of post-operative sensitivity, and it can defend against secondary caries. The modulus of elastomeric resilience lowers the shrinkage stress, which is one of the biggest challenges that we've got. The rubberized urethane in these products seem to enable a little bit more of a flexibility and not being as stiff, and actually work more condusively with the tooth rather than being so rigid and hard. And again, this bioactive patient protection works in concert with moisture challenge cases. Now, I'm not saying that you can use any resin product in a pool of water. No, you have to control the moisture. You have to protect the airway and reduce the moisture accumulation in the mouth. Otherwise, you're going to have failure no matter what you use. So good isolation is no substitute for good technique. If you don't have good technique in isolation, then how are you going to really have any kind of success? So that's very important. I tell my students all the time, if you work without a rubber dam, if you work without an isovac, isolite type of a system, or any of the other substitutes that are available, then you have the problem that the tongue is always going to get in the way, that you're going to not know if the crown is going down the right direction. And again, You only have one person swallow something to learn your lesson. So don't let it happen to you. Use the appropriate protection. A lot of people like to use an Optigate or something like that. And that's wonderful to get the lips out of the way. But the problem is that the tongue, the airway is still open. So please be aware of that and be cautious on it. We know from the work that I've done with it, personally using the material over the years and other people that have worked with it, that it has this bioresponsive ionic resin capability that you can actually use this cement on zirconia, all kinds of ceramic materials, including your lithium disilicates, CAD-CAM blocks, CAD-CAM pucks, any resin, and all of your metal structures, gold, etc. And it can be used for both crown and bridge cementation. This is not a veneer cement. So don't even put that into your armamentarium. It's not for that. This is a crown and bridge cement material. So please be very aware of that. That's very important to understand. And again, similar SEM micrographs of the interface between the tooth and the material. This is the same kind of mineralization that I have seen not in our own studies, in Ahmad's studies, and now in this study, we see how the cement, how the ions are able to actually create a hydroxyapatite-like interface here. So that's a really important thing. We're protecting the tooth, we're protecting the dentin, we're reducing sensitivity because of the mineral formation that is present, which is really very, very important and very, very helpful. Again, reality has looked at this, has given it its 4-star award, simply because it works so well. The deflection that it is able to do, the ability of it to retain. Now, again, when you're doing your preparations, you're either going to have your resistant and retentive preparations, as is ideally what we look for, but sometimes your clinical crown length is not as large as it needs to be. And then you have a resistance challenge. So we need to talk a little bit about what to do to improve that in a few moments. But the cement has been shown by various other agencies that have looked at it is very well favored, easy to use. Simple cementation process. It's self-adhesive. It's a direct delivery of the syringe material. You don't have to triturate it, and it has very easy cleanup. So again, first step, clean the tooth. Make sure that it is clean and free of debris. Try to keep it isolated. That's your best bet, in my opinion. You then inject the material into the intaglio surface of your crown. You then seat it to place. You tack cure it for just a couple of seconds. And then you're going to remove the excess. It's going to be easily peeled off. And then you allow it to continue its set over the next few minutes of time. It's going to be very easy to manage. Floss interproximally, get rid of any cement that's in there, but it's going to, for the most part, peel off very well after you tack cement it. So it's dual cured. So it's going to give you a nice overall benefit as you begin to work with this material. And again, we found this overall to work when I'll show you one of my clinical cases in just a minute. So this is from my good friend Frankie Scholl that showed this aspect. The intaglio surface of your crowns are going to be very important to understand for your gold, for PFMs, for stainless steel. If you're going to cement, you need to clean and dry the inside surface, the intaglio surface of the crown, and then apply your cement and place it on the tooth and do the steps that we just talked about. Tack cure it, clean it up, allow it to continue its dual cure situation. With composite resin, you need to use a phosphoric acid on the intaglio surface of your crown or your bridge. Rinse it, dry it, apply the material. Lithium disilicate, again, clean and dry. Hydrofluoric acid internally is very, very important. Rinse and dry according to the instructions on the hydrofluoric acid that you're using. Apply a silane. every lithium disilicate crown that you place should be silinated again after you have put it into the mouth. Otherwise, you're going to have a delamination and a debonding of your crown. So if you follow this steps, very simple, it'll make your life easy. Same thing with glass ceramics, the same basic process. Hydrofluoric acid, rinse and dry, and then silane, and then the cement. Now, zirconia is a different beast, but you can use this material on all zirconia. So after you try it in, you need to either sandblast the interior, the intaglio surface, or use something like IvoClean, which will clean out all the phosphate contamination and reduce that contamination from the saliva. That's going to happen because when you put a zirconia in there, all the phosphates in the saliva are going to go flowing onto that area and mess it all up. The next very important step after using the IvoClean or sandblasting, you should apply a zirconia primer, which contains an MDP product. And there's several products out there, Bisco and Ultradent. They all have these products, really very nice. So certainly you need to do that. And then once you've done that, then you can apply the cement in there and follow the steps that we talked about just a few minutes ago. Reinforced composite blocks, again, similar to the other materials, the lithium disilicate and the glass ceramics, hydrofluoric acid after you sandblasting the internal aspect. That's the main difference there. With the reinforced composite blocks, you do want to sandblast the inside surface of that crown. Then hydrofluoric acid, rinse and dry, put on your silane, and apply the cement. Very simple process, trying to make life easier for all of us in that aspect. Now, retentive versus non-retentive crowns. And again, you're going to come upon it. We all do. We see it all of the time. With a retentive crown, with the appropriate coronal length and good retention and resistance factors, you do not need a bonding agent. The cement, being self-adhesive by itself, is going to do the job for you quite nicely. When you do have a non-retentive crown, then using a dual cure bonding agent is very, very able to be done and should be done. And then you can use that with the cement. If you do that, you're going to have a much better long-lasting restoration. And never, 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 you don't need to use phosphoric acid on the tooth structure, because all it'll do is it'll potentially accelerate any sensitivity, even though the active ingredients in Activa will reduce that. Don't take a chance. Don't use any acid etching materials on your crown that you're going to be cementing. It just isn't going to be necessary. This is a nice article by my friend Les Reichris that was published and demonstrated Inside Dentistry a while back in this ebook, showing the various steps that he put into it. In the top figure, number 18, you see the crowns on the model that returned back from the laboratory. Everything nowadays, when you're digitally scanning, everything comes back on a printed model, which is really kind of nice. You can see how well the crowns actually fit onto the dies that are present there. So here he's got an Optigate in there, but he doesn't have any kind of tongue protection of that area. I would put an Isovac or an Isolite in there. It'll get the tongue out of the way. It'll work to protect it. Again, you will not be able to have the patient bite at that stage, but at least when you've got the crowns in place, you're going to be able to have a much more stable environment. And if they're seating properly, you check the contacts to make sure that that's not holding things up, and perhaps even consider taking a preoperative radiograph just to make sure that everything is in place. Sure makes life a lot easier thereafter. And I know some folks don't want you to take any radiographs at all, but I like to live the belt and suspenders kind of a way. If I can make sure that my margins are sealed prior to cementing it, I'm going to feel better about it personally. So there you go. The crown preparations are cleaned. And in number 20, he's going ahead and he's air drying the whole thing. He's applying the one step and the abutments on the internal aspects of the bridges. And then he's going to cement that into place, and easy peasy. He's tack cured it over there in figure number 23, and removing the excess. And then the crowns are cemented into place. Very nice, nice little piece by Les. And again, this is mine. Again, cementing this into place. We have this beautiful crown. You see the facial aspect of it and the intaglio surface. We went ahead and we used IvoClean in that area, and then used a zirconia primer with MDP. We then cleaned that all up. We then placed the Activa cement into the intaglio surface, placed the crown into the area there. You can see the excess. We tack cured it, we removed the excess, and there's the final crown in place. These are the kinds of things that you can do. And again, should I have used isolation here? Yeah, probably. But at that point in time, I wasn't smart enough. So as I get older, I'm learning how to make sure that I protect the area and make sure that I get a better overall seal and protect things. Again, material is used on zirconia, on Emax, on metals. But again, as I said earlier, not for veneers. The material can help to seal the margin of the material and the tooth interface via the creation of apatite crystals. If you have a beautifully sealed margin and you can have a seal with mineralization, that's double your pleasure, double your fun. And basically that just makes it so much nicer. It can protect margins against microleakage. Again, that's one of the most challenging things. Our patients don't take care of themselves as well as we need them to. So if you can enhance the overall result by using not only a great fitting crown and bridge, but also something that's going to protect the surfaces at that interface from the bacterial aggression, why not? And it can help you with your long-term outcomes and just make things that much better. So over the last 45 minutes or so, we've talked about a way to stop degenerative margins, protecting your crowns and your from microleakage and secondary decay. This is just one more piece that you can put into your armamentarium to help you have a much more successful long-term resultant that you've got there. And again, I want to thank you for spending some time with me today, and we'll start taking some questions in just a few moments. All right, let's see what our questions have here. Great info. Do you think MMPs could degrade chemical bond between dentin and GIC hybrids, or is it not as much of a problem on those materials compared to composites? Great question. Glass ionomers, again, have that ability to form that interdiffusion zone. There's chemical transfers going on there between the strontiums and the fluorides and everything, and the calcium in the tooth. So there's less of an enzymatic breakdown as compared to the hybrid layer formation that we see with composites. So, but you see, we're in the US, we're very composite centric. Most of the rest of the world has a penchant and a love for things such as glass ionomer, which was my first love in materials when I first looked at things. And so glass ionomers work well, but they're not as easily used because here in the States, you don't hand mix the glass ionomers, you triturate them. And very few people have triturators because not a lot of people are placing amalgams. So you have that kind of an issue. So again, with GIs, like biointeractive materials like Activa, you don't have that problem. So that's good question. Let's see. If you use a bonding agent on the tooth prior to cementing the crown with Activa to increase retention, worse, even acid etch the tooth. Don't do that before bonding and then placing on top of it. Does it defeat the purpose of using Activa? Again, if we're going to be using a bonding agent, as we just talked about, it really doesn't have a problem because the bonding agent over the course of time, initially, it's going to be hydrophobic. It starts to break down and becomes more hydrophilic. And that's where things like Activa come into play and can help to penetrate through the bonding agent and enhance the overall interface and mineralize. So that's one of the beautiful things on using that. So great question on that. In this scenario, can you use any other conventional cement? Sure, you can use any conventional cement, but the problem is that cement going to break down over time because of that interface that we just talked about as far as the hybrid bonding and the hybrid layer that we're trying to create. If that hybrid layer is broken down because of the water penetration and the MMPs start to activate, then over the course of time, you're going to have failure of the crown. So that's why I personally would advocate for something with the bioactive interactivity to prevent that from occurring. Very good. Question here. Can you cement posts with a cement? Yes, you certainly can. Again, depending on the type of post that you're using, it's going to be either a glass or some kind of a fiber post using the direction that we just showed you a little bit ago. Make sure that you're going to be able to put it into place. If you're isolating properly when you're putting in a post, and hopefully you are, because you don't want to, after root canal therapy and exposure of the tooth, that's when the tooth is at its highest susceptibility. And all my endodontic friends freak out when people go ahead and they restore the tooth without isolation. You need to do the endodontics under isolation. You need to restore it under isolation. So you shouldn't have as much of a problem, and you should be able to apply the Activa cement in that aspect as well. So great question. Let's see, what else do we have here? What bonding agents do you or the manufacturer recommend for use with Activa? At the college, we use Allbond Universal. The company has its various bonding agents. I haven't seen a problem using any specific type. So what works, but the most important thing is, no matter what bonding agent you're using, no matter what system you're using, read the instructions for use. System A may look like System B, but System A may have one set of directions that you're going to use, and the second system that you're going to be incorporating because you don't like what happened with A doesn't work the same way that your System A worked with. So if you're switching to a new bonding agent, a new bonding system, whatever, read the instructions for use. That little piece of paper in there was created by the manufacturer to give you your highest degree of success. I can't tell you how many times I have seen that fail because the person didn't read the instructions. I know we don't need no stinking instructions, but the reality is you really, truly do. Best way to bond veneers is with a veneer bonding cement. Then you need to use something specifically designed for veneers. Do not use a traditional crown and bridge or any crown and bridge cement on a veneer placement. You will regret it. So please don't do that to yourself. Find a good one. There are several out there. RelyX is good. There's a one from Ultradent, etc. There's a lot of good ones out there. Don't fool yourselves in thinking that one system is going to take care of it all. This system can definitely work with all of your crown and bridge materials. It's not a veneer material. Let's see, the intellectual part. What was the Activa brand again? It's a company called Pulp Dent. So, and again, you'll be getting some information from them, I'm sure, once this is done. The part only went over to bioactive composite. So Activa Bioactive is the restorative material. It's a resin, it's a base material, base liner material, and it's also cement. They formulated into three of those utilizations, and all three of them work beautifully. Should we cure the bonding agent if applied? If that's what the instruction for use indicates, then you should. So again, whatever it tells you to use when you're doing an indirect, non-retentive restoration, crown or bridge, follow the directions of your specific bonding agent. Can you use Activa and composite material together like a sandwich technique? Sure, they do bond to each other because they're both methacrylate-based materials, so there's no reason why you can't. Activa restorative material can be used from the bottom to the top. I like to use it, especially Activa restorative material, in the deepest boxes of our deep decayed teeth. I like it significantly better than any flowable composite for deep margin elevation because it's dual cured. The biggest problem with any and every direct composite restoration that I've ever seen is the light energy not getting to the bottom of the box. And your light goes in a straight line down 10 millimeters. That energy at the 10 millimeter mark is not the same as it was at the interface of the aperture of the light. So you have to continue to do that. Composite is an unfinished material, as my friend Dr. Richard Price talks about. You have to finish it properly. If you do not use a good light with the appropriate energy output, then you're going to create what I love to call the Tootsie Roll Pop effect. Basically, it's crunchy on the outside and soft on the inside, and you're going to have sensitivity all the time. So make sure that you follow directions and that you're using a really good light when you're doing anything there. Let's see. What's my opinion on materials like Shofu's Beautiful in combination with Activa cement? The Shofu products are beautiful. They're wonderful products. They really work quite well. But again, Shofu Beautiful products are, for the most part, restorative materials. They're not cement materials. They have a cement, then you want to use their cement. If you want to use the Activa pulp dense cement, then use the Activa pulp dense cement. So basically, again, they all create mineral very nicely. You're welcome for that. Thank you. Do you cure the bonding agent prior to cementation? What does the IFU tell you to do? Look at your bonding material and find out if it needs to be. In all likelihood, you should, but check. Does Activa contain MDP? No, it does not. It's not a bonding agent, so it does not contain an MDP in it at this point in time that I'm aware of. So MDP is typically found in a bonding agent to create the nanolayering salts that enhance the bonding capability of your and your hybrid layer to go. Thank you for the compliment, Cesar. Appreciate that. And yes, I always try to make sure that I watch the studies and I watch the papers because I can't talk about things if I don't have the evidence behind it. So thank you for that. Out of the subject, but what is your choice for cemented zirconia implant crowns? Again, implant crowns are another story. Some folks like to use a final cement such as Activa bioactive cement into the area. My question is, are you screw retained or cement retained? If you're cement retained, and what happens if your screw of your abutment becomes loose? How are you getting that sucker off? You got to cut through it. Personally, I like something that I'm going to have retrievability. I know I talk crazy in that manner, but again, I would use something that has a retrievability with any of my cementable crowns because on an implant, because every implant I ever placed, the screw and the abutment loosened up over time. It's kind of like your chair that you're sitting on. One day you're going to walk into the room, you're going to sit down, you're going to find a screw on the floor underneath your chair. Where'd the screw come from? How did it become loose on your chair? Same thing happens in the teeth. It's mechanically mesmerizing how screws will come loose, even though you've tightened them down all the way. So again, I would use anything that is retrievable, especially with zirconia crowns. If the temporary crown is cemented with a eugenol-based temporary cement, will Activa? Well, number one, why are you using a eugenol-based temporary cement? Most people don't use that anymore. It interferes with all kinds of problems, and it interferes with your bonding of any type. So I would strongly advise you remove the eugenol-based temporary cement from your armamentarium. I don't think it's a good idea. in 2024. Do I recommend Activa being used over an RMGI like Vitribond? Well, Vitribond is not a cement. So Activa is Activa bioactive restoration material. Basically, again, you could use Activa base liner instead of Vitribond as a liner. You can substitute that. You can also substitute in Limelight Enhanced, which is a single syringe application. We use that at the school. So it just depends. But Vitribond, again, is not a bonding agent. It's a liner at best. Thank you for the take. I appreciate you being on the webinar this evening. Explain immediate density on crown. Oh, great. That was just a paper of meta-analysis I was just reading before getting onto the thing. And it was really kind of fun in that it talks about the difference between delayed dentin sealing and immediate dentin sealing. And they looked at over 900 papers. And of the 900 papers, they could only use 6 for their meta-analysis. And of that, the paper indicated that there really wasn't, even though it was statistically different in between the ability of the immediate dentin sealing and the delayed dentin sealing from occurring, there really wasn't in my brain. They went from 82 to 96 on the direct delayed dentin sealing and 92 to 100% on the immediate dentin. That, again, it depends. And again, the biggest problem is you don't know the types of preparations that were done. You don't know if they're retentive or non-retentive preparations because they never tell you in the study. You don't know how deep the dentin was that they cemented it to, et cetera, and so forth. So immediate dentin sealing is interesting. But as we've just been talking about in hybrid layer creation, isn't there going to be the possibility of water activation and proteolytic enzyme activity after a period of time? So I wonder about that. But again, I'm crazy that way. So that's what I look at there. And how is Activa cement compared to Theracal LC? Again, Theracal LC, again, is a liner that's used for indirect or direct pulp capping. Activa cement, there is a Theracal cement, which works similarly to this. They both try to create mineral. And again, I haven't worked with the Theracal cement, so I really can't talk as much about them, but they're trying to do something to protect the tooth, to be able to create a mineral. So they're both, in my opinion, viable. Well, I really want to thank you. I think we've got through all of the questions. Thank you, everybody, for being on this evening. And please don't forget to take the after session quiz for your CE credit. And I really want to thank you for being with me this evening. And I hope you have a really terrific tomorrow. Thanks so much.